Hey y'all, Dr. Dana Gibbs here. Today I'm going to discuss the reasons why levothyroxine doesn't work for many patients and what to do about it. So if you're taking or prescribing levothyroxine slash Synthroid and you find that there are times when it doesn't fix the problems, this should help clear up that mystery. So as an ENT, I've been treating thyroid patients for over 20 years, helping them feel normal again, and in many cases, avoiding surgery. So I tend to go beyond just doing the surgery in my treatment of thyroid patients. Anyway, if you're listening to this and you're not a physician, please keep in mind this stuff is complex, especially if you're not trained in scientific language and the specific way doctors think about medical issues. Scientific proof is not nearly as black and white as people think. And in order to make treatment decisions for individual people, sometimes we have to consider evidence that's not nearly as absolute as we'd like. So, this is where experience and advanced medical training and consideration of the relative risk versus benefit of any particular treatment um, comes into play. Anyway, this is not meant to be medical advice, and you should consult your own physician for any medical issues or diagnoses you may have. All right, so most people know by now that T4 or levothyroxine is the storage form of thyroid hormone. It is made by your thyroid and stored in follicles and bound by protein inside the thyroid gland and then released a little bit at a time. So T4 given as a medication is the free T4. It's not bound by any hormone. It's not bound by any proteins. So its half-life and its clearance by the kidneys is actually much shorter than we were led to believe in med school. I mean, I actually heard something that made me that said that it was 2 weeks and that you could give thyroid hormone once a week, which is absolutely ridiculous. Anyway, so I went looking for data about this, and it turns out that at the time that Synthroid was licensed, pharmacokinetic studies were not required to be done. But if you checked labs on a patient throughout the day, um, you will notice if you check right at the peak, which is 1 to 2 hours after they've taken the thyroid medicine, their dose, their levels of T4, their free T4, is going to be way different than if you check a trough, which is you check the lab first thing in the morning before you take your thyroid medicine. There's a huge variation in that number, much bigger than we were led to believe. So that's one of the reasons why patients' requirements for meds can seem to really fluctuate if you don't get the test done at the same time every day when you go and get the test. So there are a couple of things that you can do about this to feel better, because what will happen is that patients will feel good in the morning and then they'll feel super tired in the evening, good in the morning and super tired in the evening. And there's a couple of other things that those widely fluctuating T4 levels can do if you're taking levothyroxine, particularly if you don't have a thyroid or if you've been treated with radioactive iodine to suppress the function of your thyroid and you're relying exclusively on that thyroid medication. So, what do I do in my practice? Well, actually, what I do is I have the patients break that pill in half and take it twice a day. So, what that does is it gives you a two peak line or graph instead of a single peak line. So you cut off the extreme high and you cut off the extreme low. And just by doing that, a lot of patients will feel a lot better. And I'll get to one of the reasons why I think that is in just a minute. But anyway, so when I'm giving my patients their medicines every 12 hours, meaning first thing in the morning and then right before dinner, um, I will check their levels, their thyroid levels, midway between those two doses. So if you take it at 6 a.m., I'll have you go to the lab at lunchtime. So instead of a peak or a trough, it's a mid dose level. Um, and what I'm looking for as an ideal on that T4, free T4, is a level of about 0.8 to about 1 or 1.1 when you're taking levothyroxine every 12 hours. So, why is this so important? Don't more people need more thyroid in the morning? Well, here's the answer to that question. So, you remember that T3 is the active form that's derived from T4 by the deiodinase enzymes in the serum or the body cells. And the main one of those is called the type 2 deiodinase, and it actually works inside the body cells to convert the T4 that's circulating in the bloodstream into T3 inside the cell where it can go to the nucleus and do its job. So we talked a while back about several ways that the type 2 deiodinase can be dysfunctional. So here's one, a genetic defect. So 15% of people with British descent may have this genetic defect in the type 2 deiodinase. Another thing that really causes that problem is Hashimoto's disease. And Hashimoto's disease is incredibly common. As a matter of fact, I think it's probably the number one reason why people in America have hypothyroidism. Maybe as many as 15% of Americans have antibodies. Not all of them eventually may show symptoms, but that 15%, that's a huge amount. So another thing that can impair that type 2 deiodinase enzyme is stress. And stress, when I'm saying stress, I'm including calorie restricted diets in stress, because what that is, turning off that type 2 deiodinase is a defense mechanism against starvation. That's what your body does when you diet with a calorie restriction. And then the other thing that does it is too much T4. And we talked a while ago about Graves' disease or acute thyroiditis, but when you're taking your T4 once a day and you have a big peak and a big trough and a big peak and a big trough, there's at least part of the time when your body perceives that you have too much T4. And if your doctor, if you come in, you say, I'm still tired, doctor, I still have this, I still have that, they might raise your dose even higher, which makes that problem even worse. And what that does, if type 2 deiodinase gets turned down or turned off, it makes the type 3 deiodinase begin to make reverse T3. And we talked a lot about reverse T3 the other day, but I'll just give you a refresh. Reverse T3 is like a key that fits in the lock but won't turn the lock when it comes to the T3 receptor in your nucleus. And so it can get in there and it can block, and it can last a really long time until your body breaks that down and turns around and starts making the T3 again. So it can be really useful to measure how much T3 you have in comparison to reverse T3 to see what's going on there. Now, when you're doing that, you need to keep in mind a lab test for reverse T3 is available, but it is protein bound. So it's more comparable with the total T3 test, apples to apples, than it is with the free T3 test. So if you try to compare reverse T3 with free T3, the reverse T3 varies a lot based on the protein status of the body, which can be all over the place because birth control pills or estrogen status or your diet can really change your protein status. So it's difficult to calculate a ratio of free T3 to reverse T3 with any degree of accuracy. But luckily, it's actually not that expensive, and it's really easy to compare that free T3 with the total T3, because that really is an apples to apples comparison. So what you do is you take your total T3, you divide it by the reverse T3, and it gives you a ratio, and it's going to be anywhere from 10 to 1 to 12 to 1 to 4 to 1 to 2 to 1. So the lower that ratio gets below about 12, the worse your patient or you are going to feel. If it gets too high, also, if it gets up above 15 to 17, it's also not going to make you feel all that well. But after 12 years of using this ratio, I'm really, really convinced that if you can keep that ratio between 10 and 14, and then also keep your T3 free and your T4 free in these ideal ranges, then you or the patient, if you're a doctor, are going to feel really, really good. So, what do you do if you're going to supplement um, with something besides levothyroxine? Well, um, combinations of T3 and T4 are best. And my personal preference is to use a combination of both the synthroid and the synthetic liothyronine, which is the synthetic T3. And the reason why I like that the best is because I can vary the ratio. So if you go for natural desiccated thyroid or armor thyroid, that always has about a 4.2 to 1 ratio, four um, 4 times as much levothyroxine as it has liothyronine in it. And that's not always ideal because some people need less T3 and some people need more T3. Some people need as much as a 2 to 1 ratio. So what's the solution? First, test. Second, measure. So an ideal free T3 is going to be a subset of the reference range. So in my clinical experience, about 3.4 to about 4 on the free T3 is where you're going to need to be. And you do need to test both. So you're going to have to test the free T3, and then you got to test that total T3 so that you can divide by the reverse T3. And so you need both of those. And then we talked about the range for T4 above. And really, it doesn't actually matter too much if a patient has somewhat low TSH, as long as their hormone levels are in that exact ideal range. Anyway, so here's another thing. If a patient has adrenal insufficiency, and I've heard over and over again, oh, people don't tolerate T3 very well. Well, guess what? One of the reasons why people get high reverse T3 is because of adrenal insufficiency. And adrenal insufficiency is what happens when you have a lot of stress. And if your adrenals can't jump up and handle that increased metabolism when you give T3, then the adrenal insufficiency is going to get worse and they're going to feel really terrible. The next thing is if they've had that level of stress and that high cortisol for a long time, they may have elevated insulin levels. So this speeding up of the metabolism when you then now give them the active T3 can cause periods of low blood sugar if they are eating simple sugars and starchy carbs. So the effect of a bad diet is really magnified by adding the thyroid hormones. Anyway, so measure, 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 supplement. That's what the effect that I want you guys to get out of this. And one more thing that I will remind you that we talked about the other day is that if you're going to give people T3 or liothyronine, it is very short half-life, and it is important to give it 2 times a day. There are compounding pharmacies that will make a sustained release version of T3, but in my experience, that sustained release version of T3 basically just gives you half as much T3. It doesn't stretch it out. You just don't absorb the other half of it. I don't know. And the patients still feel bad once it wears off. So at least 2 times a day, possibly 3 times a day. All right, guys, that's it for now. I'm Dana Gibbs, MD. I'm an integrative physician in North Texas where I help people address thyroid and other hormone imbalances. If you're a physician and you're listening to this, you need to discuss a patient with me. I do also offer consultations. You can email me at drgibbs@danagibbsmd.com. And if you are a thyroid or chronic fatigue sufferer in North Texas and you want to learn more about your hormones, I am actually going to do a 3-part masterclass. It's going to start on June 19th. It's very exciting. It's going to be at the sign up is going to be at danagibbsmd.com/course. And I am so excited to offer this, guys, to you. If you suffer from frequent illness, exhaustion, joint, muscle aches, menstrual irregularity, poor sleep issues, come and sign up for the course and learn all about it. So this is Dr. Gibbs signing off. Thanks for watching. Y'all have a good evening.